Welcome, everyone. Thank you for joining today's virtual lunch session. My name is Rebecca Cherry, and I'm part of the marketing team here at Laerdal. Just a little housekeeping before we get started. All attendees will be muted. If you have any question during the session, please share them via the Q&A feature that can be found at the bottom of your screen. We will be monitoring them throughout the webinar, and we'll have time for questions at the end. Today's recording will be emailed to you after the session is over to watch on demand. Now, I would like to introduce the moderator, Andrew Kristopik.
Hi, everyone, and thank you for joining us today. My name is Andrew Kristopik. I'm the Senior Content Marketing Manager for Laerdal, and I'll be introducing our speaker and serving as our moderator today. Before we begin, I'd like to emphasize that we will be saving time for questions. We'll have 15 minutes to answer questions today, so please put your questions in the Q&A section, and then you can use the chat feature to say hi to each other and also let us know your thoughts as we're going through today's program. Our mission at Laerdal is helping save lives. We achieve that mission by bringing you simulation products and services designed to help you train to be your best to achieve the best possible patient outcomes. And since we have a lot of emergency care providers here today, we'd like to say that we don't ever want you to have to rise to the occasion. We want the occasion to rise to you. So with that, who better to introduce than our guest speaker, who's all about rising to the occasion. Let me first just make it clear what our topic is today. Our topic is if we knew then what we know now, technology-driven tactics for teaching CPR. And with that goes resuscitation. We'll talk about that, the broader topic of resuscitation in just a moment. But back to rising to the occasion, I'd like to introduce our guest speaker, Mike Helbock, who is the Division Chief and EMS Training Chief for Seattle King County Medic 1. And he's also on the faculty at Seattle King County Resuscitation Academy. So welcome, Mike. Thank you. Thank you for representing an organization that always rises to the occasion. We appreciate you being with us.
Andrew, thank you for the invite, and thank you for your entire team at Sun from Laerdal for the invite. What an exciting next 30 minutes or so this is going to be.
It's going to be great. We thought we'd give you just a moment to say hi to all your colleagues at EMS Medic 1. So welcome to all of those from EMS Medic 1 who are following us, and I'll let you take the floor here. Mike, go ahead.
Thanks, Andrew. And I want to thank all the program team in the Seattle King County region, as well as the Resuscitation Academy. As a speaker, I always share that when it's your turn to be on stage, thank those that helped you get there. My colleagues, the leadership team at the Resuscitation Academy, originally Doctors Cobb and Kopis, Doctors Eisenberg and Ray and Kudenchuk and Michael Sayer, the team at Seattle Fire and King County Medic 1. I do thank all of them because frankly, it was all of their direction, Andrew, and help that put into play when we started developing this high performance program. So thanks for the opportunity to say hi to the team.
Outstanding, thank you. Now, before we begin, just to keep our audience engaged and on their toes, we're gonna have a polling question. We're gonna have another one later on. So I'm gonna read this polling question in just a minute when it comes up, and we're gonna ask everybody in the listening audience today to respond, and then we'll discuss the results briefly. So what would you say drives the best organizational outcomes? What would you say drives the best organizational outcomes? 1, finding and hiring the brightest people. 2, establishing professional standards based on specific skill sets. Or 3, developing a mindset based on shared values and a devotion to the mission. So if everyone would please choose one of those, and then Mike and I will discuss the answer.
Yeah, this is going to be interesting. I'm looking forward to see what they say here, Andrew.
I'm not seeing any responses coming across the screen, so they should pop up in just a sec. Outstanding. All right, this is a great group.
Yes.
Number 3 leads the way. 87% chose developing a mindset based on shared values and a commitment to the mission. So bravo. for those that chose number 1 or number 2, that doesn't necessarily mean you're wrong, but many advocates for organizational performance would have chosen number 3. So why don't we discuss that in a broader context for a moment? And we're going to transition to our first topic here in the series today: why mindset counts, how your attitude about patient survival shapes your training, or should shape your training. So what do you think, Mike? How much does mindset count?
Well, just so you know, I would have also dotted in number 3. For me, mindset is everything. About a shared mental model is what should happen when you are faced with chaos, right? Specifically, we'll talk about cardiac arrest today. If this is an ad hoc, chaotic event, quite frankly, I'm surprised that numbers would be very high in survival. This needs to be a shared mental model.
Sure.
Mindset, attitude, performance, training, all equal outcomes. So I would agree, number 3 for sure.
Very good. So let's take a look at history, since this is all about if we knew then what we know now. And
right.
Let's take a look at the history of EMS. And since we're going to talk about technology and how technology can help us in training, technology, of course, helps us in the field, with care in the field. So how have attitudes in emergency medicine changed over the years? And maybe you could also tell us about these photos. You can comment about the photos.
Yeah, you're seeing me smile there, Andrew. The photo on your left, of course, was some of the original photos from the Medic One program in our region in Seattle, started in 1969. And you pointed out an Army cot was placed in the back of a converted van, by the way. We used to work out of the back of a van. I think we talked about, just again, for history's sake, the original medic unit that was in Seattle in 1969 was a converted motorhome. We called it Moby Pig. It was this monstrous motorhome. So when you talk about attitudes, what I want to go share with you is the attitude toward emergency medicine as being a collegial part of the medical team. I would agree that maybe decades ago, it may have looked like an adjunct, right? Where today, it's an integral part of the team. It just happens to all be prior to in-hospital opportunity. So EMS providers today are given, and I'll say this, I've done it many times, there's never been a better time, in my opinion, to be part of emergency medical services now. Science is really helping drive, Andrew, what we're doing in practicum today. In the old days, so much of it was anecdotal. What might have been looked good on Monday may have been repeated on Wednesday and may just simply been protocol on Friday. And quite frankly, those days have to go away. Science is driving both with technology and through trials, clinical trials and data, which has completely changed our attitudes of emergency medicine and how it's a collegial part of the medical team. Andrew?
So collegial is a great word too, and we're just seeing some great comments coming out of the chat. People just saying hi to each other. This is a vocal group, and that's terrific to see. Do you think that? Well, let's look at it this way: the 2 photos with care back in the day, it was very much about transport to the hospital for advanced care.
Yeah.
Now it's advanced care before transport to the hospital.
Yeah.
Now, do you think with that history, that evolution, EMTs, paramedics, the field itself has become more aggressive in terms of, I'm going to keep that patient alive. I'm going to make sure that that patient can walk out the door at the end of their treatment. I'm going to prevent harm on my watch. Do you think those are attitudes that have always prevailed? They've increased, they've evolved?
Well, sadly, I don't think they've always been preached that way, Andrew. I don't. I do think that programs that have strong oversight, strong medical oversight, have heard that message many times. There's a quote from Dr. Kopis that used to always, still rings true with me today, while the original director of our program is, "Nobody dies in my rig." That's a quote, and I'm very proud of that. This idea and of in the face of cardiac arrest specifically, let's talk about that. This is that one opportunity that every provider who brings hands near that person's chest has the ability to affect change. And from 1966, original EMTs, to 69 and 70, original paramedics, to today, that has changed and it's morphed. So if we're looking at today right now, there's an opportunity for EMS providers, both EMTs, EMRs, EMTAs, paramedics, the pre-hospital providers, to make a bigger difference in cardiac arrest than they've ever been able to make in the past. I was actually originally part of the 1980, get this one, Andrew, EMT use of an AED. Prior to 81, 82, 83, EMTs couldn't use an AED. And I'm sure we've got some colleagues online, they're going, what do you mean an EMT couldn't use an AED? It wasn't used. So part of this idea was to open up the opportunity to allow these really high-performing people to do a good work. And you're right. The difference between then and now is that we don't need to take a patient to the hospital to achieve high-level care. We extend the high level of field care to a hospital for a continuance of care. And that's, I think, the big change, Andrew.
Very good. So you touched upon this a little bit, but let's maybe we could dive a little deeper. So the attitudes towards resuscitation, and to add a little extra detail to this, we're coming out of a period where attitudes may have seriously changed about resuscitation and CPR, and because of the pandemic.
Sure.
Okay. And the risk of infection. So have attitudes about resuscitation kept pace with other attitudes in EMS? And is it time to change that?
Yeah, I think that certainly if we use the pandemic as our base for this conversation, what I'm hoping is I'm looking at everybody on camera that's out there right now. Once they identify how to keep themselves safe during an out-of-hospital cardiac arrest, what I'm certainly hoping is that they still gave it every ounce of their ability to run an effective cardiac arrest. And I appreciate that there was a huge ask, right? Huge ask by people out there, both in our region and regions around the world. But in going back to this question, has attitude changed about resuscitation? Certainly there's lots of interest and ideas put into all levels of resuscitation, but also in everything else in EMS, trauma management, sepsis management. I'm not so sure, Andrew, that our focus is aligned continually through the idea of there's this one call that EMS or providers are going to go on, a cardiac arrest scenario where every single thing that they do can be measured, evaluated, and offered for remediation and reported back to the providers. There's no other call we go on. So what I'm hoping, Andrew, is that we continue to keep cardiac arrest and survival of outcomes for cardiac arrest, which means management, at the top of their minds. Even though there's many providers saying, Mike, it's only a couple of % of our overall call. I understand that, but there are agencies that completely measure their overall agency performance on how well they manage that one call.
Sure.
And I believe that. I'm one of those, Andrew.
And we'll get into that a little later in the program. We're gonna talk about how performance in resuscitation impacts everything else. One thing that has always struck me is your attitude out there and the attitude you teach at the Resuscitation Academy, that everyone lives. And I think that is the hallmark attitude that shapes everything else, right?
We believe when we approach a cardiac arrest, Andrew, we expect change. That is our culture. We expect it. We understand it may not always happen, but we go in with the idea of expecting to be a change of the patient. Certainly, we expect survival of VF and PVT patients, which are shockable rhythms. We expect all of those to survive.
Sure.
But I'll just pull back and say we expect change. Thanks for pointing that out, Andrew.
So we'll only be on the next slide briefly, and this doesn't show your mobile home.
Yeah.
We need to get a photo of that for everyone. It's a classic. But what were sudden cardiac arrest survival rates out there in King County before you all embarked on the journey towards high performance
Yeah, a great
resuscitation?
question. In fact, our leadership team, those names I offered early, Andrew, were the driving force for what we do today. And we sat using, there's two sort of ideas, right? There's the Utstein criteria, which is a shockable rhythm, originally developed in 1991, published in 91, that said those are the patients that truly have an opportunity to survive. But certainly we track all patients. So all comers, asystole, PEA, profound bradyarrhythmias, et cetera. We were frustrated, Andrew, because we sat in decades at somewhere around that 30% mark for Utstein criteria, shockable rhythms, and somewhere in the 10, 11% mark for all rhythms. And we tried numerous things to get out of that, to break out of that. It wasn't until we really started to understand the science, and our medical leadership, again, those names that I shared earlier, gave us very clear direction. Relook at how we're doing business, not just adding things and adding people and adding equipment, but maybe, just maybe, the culture of how we are attacking a cardiac arrest needs to change. And that's where it all started back in about 2005, early 2000, when we started to look at ourselves and realize, quite frankly, Andrew, we weren't as good as we thought. We started to look at our performance. We started to look at how we trained. We started to look at how we remediated. And once we really developed this high performance option, everything changed. Within the first year, we increased survival by 13%, Utstein criteria. And when 2 to 3 years after that, Andrew, we doubled survival in our region. No new people, no new drugs, no new equipment, a cultural shift, a can-do attitude.
Yep. So maybe you could tell us about your survival rates today, and how, I think you just touched on it. It's all here, right?
Yeah, it's and what I say with everybody, and if you're listening, I see we even have people in Europe as well. What I share this when I share this part with everybody, Andrew, it's not the number we're looking at, it's the upward trend in performance, right? We don't care if your number was 5, 10 years ago and it's 10 today. To me, that's double survival. This is attached to people and numbers. We essentially doubled our rates. Utstein criteria. We fell down a little bit during the pandemic, like I believe many of our colleagues out there have. But we look at numbers more of the idea of a trend. We're always looking for an upward trend. When we see a dip, we don't chase a dip like in a 6 month, because that's not a trend. But we chase things if we see a year or 2 or 3, maybe. So our numbers right now, they're not as high as they were pre-pandemic, but we're still holding a strong number well into the 50 mark.
Okay, well, bravo. That's outstanding.
And here's one last thing I'll say is that there's people out there in the world right now, Andrew, that are actually surpassing these numbers because they've employed this concept, the very thing you're talking about, measurement, improvement. How do we get better at what we're doing?
Outstanding. So that's we're going to segue now into a different, just now that we've got attitude down, we're going to couple that with knowledge, and the idea that knowledge is power, especially in this field, and why knowing the science is important. So from your perspective, we'll talk about we're going to talk about a key performance indicator, and then we're going to give everybody a pro tip. We could probably spend hours going through different performance measures, and we'll get to a few later, but there's one key performance measure, just like every sport has a key performance measure, every business does, every type of performance has some key performance measure. Chest compression fraction, some of the most important math you'll ever know, and I know you're going to say it's more than just math, so take it away.
Sure. So first of all, I love the question. This statement, the overall statement, is science important? The answer is absolutely. And in fact, our colleagues that are even signed on today, these are smart people, Andrew. These are people that by profile always want to do the right thing. I do believe, though, if we can teach them the why, they'll be able to perform the do, right? So the why is, why would we be using this? Why would we be thinking compression fraction is important? Why is it important to understand depth and recoil and rate? Well, if they understand the science, which currently, again, as I shared, is some of the best we've seen so far, they'll understand compression fraction. Let's pull back 15, 20 years ago. I anticipate that many of our colleagues on right now had no idea what compression fraction means, because compression fraction, frankly, is a matter of pauses. It's all about pauses. And my colleagues, like I did, Andrew, paused for a lot of different reasons. Some are completely appropriate. I get that. But I'll tell you, many are not. They're unnecessary. So compression fraction has been well defined as essentially the percentage of compressions during a given period of time. So I love this slide, by the way. We used an 81% just as a quick tick. This was actually a real testing scenario. We just used that. Let me quickly explain how to achieve this. Now, Andrew, as we discussed the other day, compression fraction over the duration of an arrest, 20 minutes, 25 minutes, will be X. I want to pull it and truncate it a bit and let our listeners understand how to achieve what we ask for is a 90% compression fraction if they're doing 30 to 2, and a 95% compression fraction if they move to continuous. Here's how you would dial in a 90% compression fraction using 30 to 2, using just 2 minutes of time. You would need to do 108 compressions within that period of time. You can only be off the chest for 12 seconds. So in a 120-second period of time, 108 of that has to be compressions. Only 12 seconds can be off. Some of the listeners are going, Mike, I got it. No problem. Others are going, I've been tested. I'm not quite sure I hit that. But Andrew, here's the third group. I think there's a group out there that they actually don't know what their compression fraction is. And that's the group that we really want to talk to. You get it through measurement, through both training measurement, instrument mannequins, or through post-event analytics. And a high compression fraction has an absolute correlation to an increase in survival, Andrew.
What I like about the idea of making that a core KPI, a core key performance indicator, is that it forces you to drive out any waste in your process.
Absolutely.
And so what are some of the forms of waste that can rob a patient of good chest compression fraction?
You are asking all the right questions, my friend. That's an excellent. The first one, I'll be honest, if you have an AED, that's maybe an older style that requires all hands off for analysis. There can be no compression during analysis of an older AED. Some AEDs don't allow you then to compress during the charge feature. So those can be anywhere between 18 to 20 seconds or more off the chest. Other reasons are if you're not using advanced skills and during compressions. In the old days, Andrew, that airway procedure, whether it was an iGel or certainly an endotracheal intubation, it was always hold compressions during this high-level skill. At this, what we know today, something we discussed, is that the science is out. If you are still performing unnecessary pauses in your evolution today, that's on you.
I'm just going to pause 1 minute. If we could just go back 2 slides, please. There we go. I want to just keep us focused here and make sure that we really cover these interruptions that can impact chest compression fraction.
So we talked about an AED. We talked about advanced skills. If you're pausing to perform advanced skills, and a highly inefficient choreographed evolution, movement and rotation will actually have unnecessary pauses. Another one is a pre-shock pause, the idea of pausing prior to defibrillatory shock. I shared part of my AED scenario. That is one of the egregious, but frankly,
we'll get to that in just a moment.
Yeah, no, I'll be honest. One of the others are your paramedics, your folks using manual defibrillators out there. If they are not offering compressions right up to the last quick look, that's an unnecessary pause too. Every pause decreases compression fraction, and every lowered compression fraction is a reduction in chance for survival, Andrew.
If I could throw in one other debate about who does what.
Oh, yeah, that's not knowing what your plan is before you attack, right?
Sure.
All these have to be predetermined prior to arrival. If you're carrying in the AED, you're in charge. If you bring in the event kit, you're on the airway. If you have nothing in your hands go on the chest. So right, pre-arrival understanding of sessions. Spot on, Andrew.
Very good. Thank you. So let's go to pre-shock pause. And so here's where and I know that you'll probably add some more pro tips as we go along. And there's one, another key performance indicator that we'll talk about a little later, but pre-shock pause and depth. So pro tip, we
Sure.
already talked about how pre-shock pause can rob a patient of good chest compression fraction, but it also can impact defibrillation success. So why don't we go to the next slide, and we're going to talk about this paper a little bit. And I think it's a gem in the world of resuscitation, and I'm often surprised it doesn't get the attention that it perhaps should. So go ahead.
No, it's excellent.
If we could just go back to that first slide just for 1 second.
Sure. So this was a study done many years ago. I think it was in 2006, I think is what I remember. And it was the idea of how can we maximize defibrillatory shock, Andrew? And it's this idea of what can we do to maximize the opportunity for the shock to work? Well, the two things they looked at was the pre-shock pause, which is the pause leading up to defibrillatory shock. I've shared some of those already. AD usage, maybe the non-usage of a pre-charge, things like that. But the next thing they looked at in this study was depth of compression. So certainly we know the depth is 50 to 60 for my metrics folks, or 2 to 2.4 for us in the States. And the study looked at if you increase pre-shock pause greater than 10 seconds, what was the efficacy of effective defibrillatory shock? As well as if we were shy on depth of compression, how did that affect the defibrillatory shock? Well, what was very clear during this study was that any pause less than 10 seconds had a high efficacy in defibrillatory reversal, right? The shock worked. And the same, as long as compression of the chest was at least 50 millimeters or the 2 inches, then defibrillatory shock again was effective. This doesn't measure outcome. It measures the ability for defibrillatory shock to work, because you and I both know there's only 2 things that'll save somebody in out of hospital cardiac arrest. That is high quality compressions of the chest early and effectively, and defibrillatory shock if they're in a shockable rhythm. Those are the only 2 things we know for sure. This was an excellent study that validated that, Andrew.
Well, here's another opportunity for you to comment. Clear, I'm clear, you're clear, we're all clear.
Oh my gosh, let's do it really quick. I don't want to burn time. I was part of that original program. For all my colleagues out there that have been in the system for 30 plus years, I'm going to apologize to you right now. Back in the early 80s, we gave AEDs to the hands of EMTs, which, by the way, was not done in the country. And in order to make sure they were safe, we developed something along with Doctors Cummins and Judy Graves, certainly helped develop this, was I'm clear, you're clear, everybody's clear. I call it now, affectionately, the AED hokey pokey. Quite frankly, it's a 5 to 7 second pause to back up, to get shocks. When we started looking at that for efficiency, we realized highly inefficient, and we developed the word hover, where we put our hands 2 to 3 inches above the chest, offered defibrillatory shock, back on the chest. No loss of time, Andrew. You took me back 40 years, my friend. That was fun.
Well, wouldn't it be great if we knew then, right?
If we knew then what we know now.
So we're going to transition to our next part of this discussion, and before I introduce it, I want to remind people, please, if you have questions, please put them in the Q&A. There's some great chat going on right now, but if you can please log your questions into the Q&A feature, that's where we're going to go to make sure that Mike gets your questions 15 minutes before the top of the hour. So our next topic is teamwork. Why a team of experts does not necessarily guarantee you an expert team. So let's talk about teamwork. Why is chaos so dangerous? And maybe you could go back and comment on your own experience. The team of experts does not necessarily guarantee an expert team.
Yeah,
And what have we learned about teamwork over the years?
I agree. So I'll jump on the first part of the sort of the global issue you have. If we have, does a team of experts mean we've got it? Well, the answer is not necessarily, right? I mean, it could be, but not necessarily. Just because we have a team of experts doesn't mean we perform expertly. That it's this idea of the science and the reality to operationalize what is in the minds of these experts, right? So if you are watching or following current science today, and again, I believe it's some of the best we've seen in absolutely decades. The real key to this, Andrew, is to not just see the expert data, but more importantly, how to operationalize it and put it into practice. We need those experts to guide us in the delivery of science, but they need us, meaning us practitioners, to operationalize it to match their actions and their science. So just having a team of experts doesn't put you in an expert team. What I believe is, and I shared earlier, the people that are online right now, these are some of the most wonderful people I've ever met. Why? Because give them a task and they will complete it, but you've got to give them direction. And more importantly, ask them to take ownership of that task and they'll take it to a completely new level. And that's one of the things that we saw early. Let me now answer this question. Is chaos dangerous? Absolutely. In fact, it will kill it. It'll kill an evolution faster than anything. This needs to be a well choreographed, expertly performed evolution that needed to be trained prior to the event. Figuring it out at the time of the event, you're behind the curve. One of the things that we learned early, Andrew, was to give the ownership of the compression and the ventilation to our initial providers, our EMTs. And I think some of my colleagues out there have seen the same thing. Let's say some EMTs were at the scene first, and I'll just use initial providers. It doesn't have to be a skill, initial providers. And then the next level of skill comes in, possibly paramedics. Guaranteed 90, 100% of all those providers would stop, ask the next level of provider, what would you like me to do? Sort of this sort of chain of command scenario. We allowed that to go on for decades until we realized you're pausing for no reason. Let's give you the ownership of that. That way we'll simply integrate our skills into yours and we'll eliminate chaos. Andrew, I can guarantee you that was one of the number one things that we use in our system to increase performance. Give ownership of those to the initial providers of their skill.
So we're going to stay here for just a moment and continue talking about teamwork, because you all have choreographed your team performance to a Six Sigma level. All right, you have taken every possible waste, a bit of waste out of the system, and that waste goes back to chest compression fraction. And you've used NASCAR, I think, as one of your models. Can you talk about how have you used simulation and your other training to identify areas of waste, and how do you keep chipping away at that? Because I know you've got a continuous improvement effort out there.
We do, and I appreciate you asking that. I know that when we started to look at ourselves, we realized, again, we've looked at this study. It was done many years ago called the Observe Perceive study. How do you perceive how well you do? How do you actually, once observed, how you really do? Once we started to use really an instrumented mannequin, actually one of the Laerdal products, by the way. And by the way, I need to say that we stay very product agnostic where we're from. We try to make sure that we're only using products that we like. And frankly, your product was one that we used. Why? It gave us the metrics that we needed of proper depth, compression depth, rate, recoil, ventilation volume, and then it came up with the ability to develop compression fraction. We never had that all the years earlier. So once we started to utilize this device during training, That's when we developed our plan of action. We taped ourselves. We actually put videotape on ourselves, started to extract out unnecessary pauses, and that's what allowed us to tighten up the program. Couple that then with an actual post-event analytics, and then you can start to see a pattern. If we're seeing high compression fractions in training, we should be seeing high compression fractions in field. And if there's not, we have a disconnect. That's what we started to look at.
Excellent. So you are that high acuity, high performance team out there. So let's talk about how that translates into excellence in other areas. And I think you've got some great comments about how this does impact everything. So go ahead.
I can't stress, this question is a really good one. We didn't see this one coming. Well, maybe some of our smarter guys did, but some of us that are in the trenches doing all this training didn't see this coming. What we noticed, once we developed this high performance evolution of cardiac arrest, this idea of, like you said, getting rid of unnecessary waste, extracting the things that don't matter, excellent closed loop communication, prior knowledge of our positions prior to arrival, we started to see everything else change. What I mean by that is code STEMI started to clean up, code sepsis. We actually developed high performance trauma care packaging based on the model of high performance CPR. What it was simply our providers understanding that by watching and learning and training, remediating and performing, that every single thing we do can be elevated to a new level. I'm not saying we've hit everything. We've got colleagues on the talk right now that are doing wonderful things out there. And I want to just make sure that I say, continue, keep it going. You're doing great work. But what we realized that by cardiac arrest management, which frankly we use as a measurement of our overall system, Andrew, can be employed in other areas of pre-hospital medicine.
Outstanding. And you really have moved the bar in so many different areas of emergency care. We're going to transition now over to the last portion of our talk today. But before we do, we've got another polling question for the audience. We told you we'd have one, so make sure everybody's still with us. So if you take a moment, please, to answer this question. How would you describe your approach to resuscitation training? 1, we are disciplined and we use the latest technology to verify everyone's performance. 2, we are disciplined, but our ability to verify everyone's performance needs work. 3, we have an inconsistent approach, but we're actively working on upping our game. And 4, we have hope, but we get that hope is not a strategy.
Andrew, I'm going to be very interested in see how this comes out. I think I know where it'll go, but we'll see. We've got some pretty talented colleagues out there. We'll see what happens.
And we've got some honest ones too. So this is great. So the majority came out, and I'm reading this for the sake of those who will be hearing this as a rebroadcast. 51% chose we are disciplined, but our ability to verify everyone's performance needs some work. And then 25% said we have an inconsistent approach, but we're actively trying to up our game. 21% said we are disciplined and we use the latest technology. And 3% are working on hope, and we're going to try to get you beyond hope and give you a new strategy. So good on all of you for answering those questions and answering them candidly. So let's talk about technology, because it ties everything together. It allows you to tie together your attitudes, the science, teamwork, performance. And it really, in today's technology, because it has, I hope you'll agree, come so far that it kind of leaves us no excuses.
Yeah,
right?
Andrew,
because we can measure everything at this point.
I absolutely agree with you, by the way, and you're right. The excuse is gone. The opportunity now is in front of us.
So if we could just, right. So here's a great view of what we're able to deliver today. And we talked about one KPI, which is chest compression fraction. But now we can actually see, we can see if somebody's leaning on the chest. We can see if somebody's approaching with an incorrect angle when they're doing compressions.
Yes.
We can not only tell if somebody's delivering proper ventilations, but we can see their technique, and we can see a whole team performance. So we can do a true debrief. We can either pause during training and do a timeout debrief, or a debrief after. Do you wish you had had that? I mean, this is a loaded question, of course, but how would you have approached training way back when, or do you wish you had had these tools way back when?
Well, of course, the answer is absolutely. But let me play off this a little bit more. Let's read the question. What if we had today's precision training 10 years ago? The question is, what might have been different? Here is going to be my mic drop answer. We would have sent more people home to their families. And I mean that. It's training. It's training that allows us to perform. So I've been in for almost 40 years. It's a long time, probably older than some of the folks that are out there. And I think about my early time when I was trained. And I'll be honest with you, I thought we were doing a good job, but let me show you. You're going to watch my head here in just a second. This is how we determined proper depth and recoil 30 or 40 years ago. Yep, that looks good enough to me. That's how it was. And then we started to get mannequins that gave us some level of measurement, and they were good. They gave us ventilation and some compressions and recoil. But what we have today is better than anything we've had before. Had we had this 10 years ago or 15 or 20 years ago, we'd be having this conversation of what the new thing would be today instead of what we've worked on. I'll tell you, colleagues that are out there, there's an opportunity for you to increase performance in cardiac arrest management and survival within your community. This does not take a huge system to pull off. Identify one or two key measurements within your department and go after them. You can do this. And then once you've mastered those, take on two more. And there's all these different pieces. So the question's powerful, right? Everything we do is with the idea of sending more people home. Had I known that, more people, I think, would have gone home today. So that's why I'm on a quest here, Andrew, to get as much out and share as much as I know of what I've learned over the last 4 decades before it's my time to say goodbye.
And your quest is also about getting them out the door neurologically intact. Someone asked that question, and that is your goal.
That's absolutely right. Survival, and I'll share with you, I know we only have some time, but 20, 30 years ago, we used to measure survival in our own world, even though the Utstein criteria from the Abbey at the Utstein Abbey from Stavanger made it very clear what survival was. But for those that didn't know it, they used to think if they just got a ROSC or a pulse back and got in the hospital, win-win. Well, I'm going to tell you, you did a good job, but that's not what survival is. Survival is walk out of the hospital, CPC score of 1 or 2, neurologically intact. And frankly, Andrew, these agencies that are employing some of these different technologies and training and ideas and tactics are seeing those numbers like they've never seen before. I get emails all the time about having people wake up during compressions, or they came to visit them 5 to 7 days later at the squad or the firehouse to thank them for that. I've never heard these more than I've heard them today, Andrew.
Well, I have to say, you really touched a chord with me, and I'm sure with our audience on that one. So I'm kind of having to collect myself a little bit here. So thank you. Let's talk about, we've got just a few more moments before we go to questions, but let's talk about how measurement, assessment, and feedback shapes a culture of excellence.
This is actually critical because all of the work done in training and to prepare us for the event is important, 100%. And even those training analytics, by the way, with some of the equipment, certainly some of the Laerdal devices, allow us to review those, right? So they can feedback immediately, both at training or even later on because they go to the cloud, they're captured. But let me share this part. If you're a training organization, it is critical that you develop a feedback loop that puts the performance back into the hands of those people that are doing the work. If you capture the data and hold it close to your chest, all you're doing is collecting data. And we're data people, but you've got to make a loop, put that back into place, specifically post-event analytics. Every device has the software to do that today. And I really encourage you to use these devices, the data, put it back, review it, annotate it, put it back into the hands of those very providers. That, Andrew, will not only continue to build a culture of excellence, but will also give you very clear direction about needed performance.
Outstanding. Thank you. So one more before we take questions, and that's this. What is your favorite, if we knew then what we know now story?
I'll take just a few minutes. This one's real. And I'm going to do a quick plug of a very close friend and colleague of mine, Dr. Mickey Eisenberg, who wrote a book called Resuscitate. If any of my colleagues are out there, by all means, go after it. It's a book called Resuscitate. The reason I'm sharing this, because he asked me this exact question in the book. He said, Mike, what was the difference back in the 70s or 80s versus today? Here's the answer to this, Andrew. I came from a neighboring county, not Seattle or King County. It was a neighboring county, a small department. We were a good group of providers. We worked very hard, worked for local hospital. But the reality is this: for the 5 years that I worked in that agency, I never had one resuscitation of cardiac arrest, not one. So my version of what a cardiac arrest was to do the work until they called them dead at the hospital. That's the only thing I knew. So here's my story. I moved to Seattle to the King County system in the early 80s, where Doctors Eisenberg and Kopis and Cobb, the very leaders I talked about, were developing a way to pull this off. Within 1 week of working in this fire department, the one I moved to, Bellevue, Washington, which is a very, very well-run fire department, within 1 week, we got pulses in the field, we got ROSC, we transported, we took them to a local hospital, and 5 days later, this little girl shows up at the Medic 1 door with a bag, this biggest bowl of fruit I've ever seen, and right behind her was her father, the one that we resuscitated a week earlier. That's my story. I came to a system that used cardiac arrest as a measurement of the program, and the rest is now history, Andrew.
And we're supposed to continue after that. That's beautiful. Absolutely beautiful.
It's just a true story.
Absolutely beautiful, and it's amazing to hear stories like that. Everybody in EMS should have stories like that, and everybody in emergency care and hospitals too, and in our military.
And I know our colleagues, I don't want to burn any more time, but our colleagues, so many of them have similar stories, Andrew, and those that are really going after cardiac arrest to improve are having more of these stories every day.
And we should live for stories like that.
A great story. Yep,
absolutely. Thank you. So we are going to take a few questions. And one that didn't make the Q&A, but I want to circle back on because it's important to how you teach teamwork. Someone wrote, I've got a lot of turnover in my department. How do I teach teamwork in my department when I've got so much turnover? What are your thoughts? And we unfortunately have to make these sort of lightning rounds. We've got time.
Well, the first question is, why is the turnover, right? I mean, you don't want to try to chase something. Why is the turnover? We probably won't be able to answer that. What I would do, though, is I would make it very clear that your agency, if you choose to use cardiac arrest management as a measurement of your program, then everyone who comes into that program understands that right up front. And however long we're going to have you, we're going to measure to make sure that the next cardiac arrest that we run will be highly effective, choreographed, and fully measured, that we have an increase, a chance for survival. Again, we can't answer the turnaround, but we can sure answer our culture when you come into our department. That would be my lightning round answer.
Sure. And you have protocols, and you have, I mean, you're constantly teaching two procedures, right? You have a very choreographed playbook.
Yeah, no, Andrew, it's a great question, but I'll tell you, we give a lot of creative sort of license to those individual providers that day. For example, you'll have aid 1, aid 6, aid 12, engine 10. They have different people, different numbers. So we let them decide how best to run that after giving them the boilerplate of what to pull around, right? You,
Sure.
again, give them ownership and they will figure out the right path. So it's not scripted that way, but there's no doubt they've got benchmarks they have to hit, Andrew.
Very good. Here's another question, and I'm going to try to put a twist on this. The actual question is, I know what I teach, but what specific techniques do you use to reduce pause time? So you talked about some of the things that rob someone of chest compression fraction, but do you use any limericks? Do you use any, it could be graphics of some sort? Are there certain reminders that you use to drill points home to people?
Here's the answer. This one's going to be a really easy one, right? Film it. Put an iPhone on it. Let them run a 6-minute evolution on whatever mannequin you have. Film it for 6 minutes. Bring it back. Put it in front of everybody there. And I guarantee you will identify probably close to a dozen inefficient moves or pauses that need to be eliminated. Remember, some can't be eliminated. I get that. But you will, as a team, start to rebuild by simply watching your performance. That would be my advice.
Outstanding. Thank you. Now, here's another one. This is just a refresh. You mentioned the alternative to I'm clear, you're clear, we're all clear. Could you just repeat?
Of course. Thank you. So you got the I'm clear part. We looked at that and tried to identify how long that took. It was a 5 to 7 second pause for us. By the time we all pushed back and then shock and then all pushed up and found position. So we developed something called hover. Hover our hands together over the top of the chest, 2 to 3 inches. So what happens now is we rotate in, we tell the provider to hover, we we analyze the rhythm or do a pre-charge or a shock. They're hovered off the chest. We clear everybody, shock, touch, back on the chest. So that hover eliminated this 5 to second pause by movement by putting the hands only 3 to 4 inches off the chest wall. So the minute the defibrillatory shock is done or a call for compressions, we're back on the chest, minimal pause. And we identified that by videoing us. We didn't even know we were doing it.
There you go.
That's how we did it.
Video doesn't lie, right?
It doesn't lie. And again, I apologize. 40 years ago, I thought it was a great idea. I'm pulling that back 40 years later.
So here's another question. What about the importance of proper ventilation during resuscitation? So we talked a lot about compressions, and really that was very much for the sake of time and trying to get down to the absolute essentials.
Yes.
But have at it.
Yes, absolutely. So colleagues out there, I'm speaking to you directly to camera. We have been overventilating and hyperventilating for decades. I'm asking you to pull that back. There are ways during training with instrumented mannequins that'll give us some idea. When we wrote High Performance, we actually use a 350 to 500 mil top frame for ventilation or initial chest rise with some movement. So in other words, just enough to get that chest right and get a good movement to it. Certainly in training, you can measure this with some of the instrumented mannequins. I do know that there's some new equipment out there that's starting to come into the world, not just waveform capnography, but actually volumetric opportunity to see how we're doing. But I'll tell you, everybody, you don't need as much as you think you do. Once we identified that, the Seattle team actually dropped their bag to about a 700 or 750 cc bag. As most of my colleagues know, most of these bags are about 1,900 to 1,000 cc's. The other thing we did was we pulled the pinky finger off. We went to a bunch of orthopedic surgeons and asked them, how can we reduce the crush factor on a bag valve mask? And the question is, lift the pinky and then all they're using is the first three fingers. So we developed something called the 3-finger technique. And by the way, all of these are in videos on the Resuscitation Academy website. Believe it or not, we put 300-pound truckmen with pinkies out ventilating patients and found them to be in proper range, Andrew.
Neat. Absolutely neat.
Long answer, but
no, that was spot on. That was great. One more, and then we're going to bring it to a close, and we only really have a minute for this one. What does a typical QA, QI of a CA event look like in your department? And how essentially, what does your debriefing method look like?
Perfect. So there's usually a hot debrief immediately after by EMTs and paramedics of the case, but then the case is uploaded and sent to either Seattle, King County, a regional review process, or a local medical director. So the uploaded data comes to them. Often within 24 hours, some of these agencies are able to get the data, review it, annotate it, and send it back to the providers before they get off shift the next morning. That's not everybody, I'll tell you that. That's ideal, but it's not for everybody. But every single provider will get a review from either the medical director or their designee with a printout of the analytics and to either look at validation or remediation. That 360 feedback loop is critical in increased performance and a culture of excellence, Andrew.
Very good. Thank you. So we're going to wrap it up. And the first most important thing in all of that is to thank you, Mike, for being with us today. You've been terrific. You've been inspiring, and it takes a lot to get me choked up, but I think you choked me up, and I'm sure you did the same for our audience. So stick with us for just a moment, if you would. And for the audience, let us support your high performance resuscitation training initiatives. If you are looking for the types of technology that will allow you to put a positive attitude and a good attitude, the science and great teamwork skills to work, we can help. We're there to help you. And as by way of resources, first and foremost, we'd like to invite you to join our simulation user network. And we should have a slide coming up about that in just a moment. And the sun is coming back. So you're here attending a virtual sun right now. And we've been running these ever since the world went virtual, but we're bringing back the in-person sun. So we invite you to become a part of that community and check us out in Houston, September of next year, September 12th through the 14th.
Beautiful.
You can also find resources online. So first, if you'd like to learn about our products and services in this realm, there's a link right there. You'll be receiving a follow-up email for attending today, asking if you would like more resources to achieve better resuscitation performance. You can also call us at 1-877 Laerdal. There's certainly our webpage, and there you see a link to our Facebook Sun community. So if you want to talk to experts like Mike, that is the place to go. Please become a member of our Facebook community. So with that, we'd like to say thank you. Mike, I want to say to you, and I want to say to all our listeners, happy holidays. And I just have to say, no better topic to enter the holidays hearing about and focused on. And that patient save story that you told, the little girl coming to the door with her father. Wow.
True story.
If we can go into the holidays thinking about that and creating our own stories like that, what a holiday miracle. So thank you.
And I want to thank you, Andrew. You've been just simply exquisite on this and your entire team. I do a lot of presentations, and I'll tell you that you're absolutely a top tier group. I appreciate it very much. The opportunity to share with our colleagues that you know I care about out there. And if there's another opportunity to help in the future, happy to do it.
Thank you very much, Mike. Thank you, everyone. Thank you to the Laerdal team, because there's a lot of people that have worked on this. Alyssa, Mary, Rebecca, who are online right now, making a lot of things happen behind the scenes. You're all fantastic, and I'm humbled at your words, Mike, and certainly privileged to be a part of the Laerdal team. So thank you. Okay, happy holidays, everyone. Make it a great one.
Be safe, my friends.